Ask them to mute. Good evening to everyone. I am Dr. Onkar Swami on behalf of MQ Pharmaceuticals Limited, Pune. Welcome you all in this third module of No Thrombosis workshop. I'm very happy to share that in last first and second module went very successful with the participation of 2,000 interventional cardiologists across the country. As we all know, the objective of this workshop to share knowledge and insights about vascular intervention and imaging by series of live inbox discussion by interventional cardiologists across the country. These workshops will be conducted every fortnightly on Friday with 3 interesting cases in each workshop. At the same time, I feel very privileged and honored to welcome our course director, Dr. M.S. Hiremat sir. As we all know, sir is a director at Cath Lab, Ruby Hall, Pune, India. Sir is a past president of CSI 2017 and convener for National Interventional Council of India, CSI from 2004 to 2006. Sir has proctored many interventional cardiologists and given live course across the globe. Though coronary interventionalist at heart, he is equally adept at peripheral arteries and interventions like leg, carotid, and aorta. Sir has also participated in a groundbreaking trials as well. Thank you very much, sir, sparing time every fortnightly with us and bringing very important clinical insights from each of the cases and which made be very successful this program. We are indeed very much privileged and honored to have you as on board as a course director. Welcome you, sir. Thank you very much.
Thank you, Dr. Onkar, and good evening, everybody.
It gives me a pride, privilege, and honor as well to welcome and introduce Dr. Jabir, sir. Sir is Senior Consultant and Director at Clinical Research Cardiology at Lisi Hospital, Cochin. Sir has a vast experience in cardiology and well-recognized cardiologist at national level. And excellent work in management of complex heart disease has been done by sir. And sir has been well recognized by peers, colleagues, and patients. And sir's interest is coronary intervention and heart failure. Welcome, sir. You are also been a part with us as a moderator for last 2 sessions, and it is indeed a privilege to have you and have a discussion with you. Thank you very much, sir, and welcome to this program. I also taken a privilege to welcome and introduce Dr. Nagendra Chauhan, sir. Sir is currently Director and Interventional Cardiologist at Medanta, the Medicity. Sir has more than 20 years of experience of cardiology and performed more than 10,000 PCI to more than 250 towers and participated in more than 50 clinical research papers in a national and international journal and a regular invitee for the lecture for international and national forum. And interestingly, sir is reviewer for Heart, International Journal of Cardiology and Indian Journal of Indian Heart Journal and many national journals. I also welcome our speaker, Dr. Ankur Tumar. Sir is consultant interventional cardiologist at Sterling Hospital, Rajkot, and sir will be presenting a nightmare during left main stenting in ACS. I also welcome Dr. Sudham Jare, sir. He is a chief cardiologist and director at Cath Lab in Ahmednagar. Sir will be presenting primary PCI complication, thrombus in LCX. I also welcome Dr. Sachin Hundekari. Sir is Chief Consultant and Interventional Cardiologist at Ruby Healthcare, YCM Hospital, Pune. Sir will be presenting on the very interesting case of lost renal stent. So with this, I would like to hand over this session to our course director, Dr. M.S. Hiremat, sir, and beg your pardon. Over to you, sir.
Thank you, Dr. Onkar, and this is what we have for today. I think these sessions are always very interesting because no 2 cases are similar. And I would very strongly believe that we are all working in the range of 95% to 100% professional accuracy. So we all try to do our best and we all learn from these cases. So that's the little beginning. And Dr. Tumar is ready?
Yes, sir. Dr. Ankur Tumar is already joined, sir.
Okay. Dr. Ankur, you can start sharing your screen and let's have your presentation.
Yeah, sure, sir. Am I audible?
Yeah.
Am I audible?
Yes.
Okay. So Today my topic is nitrophilic left main stenting in ACS. Next slide. My patient was 45-year male with family history of premature coronary artery disease. Patient had NSTEMI. His EKG showed biphasic T wave in V2 to V6. That's we called Whelan sign. His echo suggestive of RWM in LAD territory with ejection fraction of 35 to 40%. Patient was loaded with DAPT and immediately shifted to cath lab. Next slide. Run first. Yeah. This is his angio picture. Second one. Yeah. Third one. Yeah. Fourth. So in this angio, we can see there is critical stenosis of LAD ostium. Next slide. So our option was for ostial LAD stenting. Option A, pure ostial stenting, and option B, left main to LAD crossover stent. Next slide. But as evidence is in more favor of left main to LAD crossover, which ensure adequate ostial coverage, we had planned to do left main to LAD. So first LAD, previous slide. So first BMW wire was parked in LAD and lesion was pre-dilated with 2.5 by 12 millimeter pre-dilatation balloon. Next slide. And 4 by 24 millimeter ultra thin stud sirolimus eluting stent was deployed. But while deflating the stent, when it reached up to 7 atmosphere, we noticed migration of stent proximally. As we can see in third run, stent is significantly migrated proximally and half part of stent is hanging in the aorta. Next slide. So stent migrated proximally and half stent was hanging in aorta. So at this point of view, what we thought is we had gone up to 7 atmosphere only. So stent is not fully deployed. So same stent balloon we withdrawn and distal part of the hanging, we kept proximal part of balloon in the distal part of hanging stent and we inflated the stent at 14 atmosphere. And wall assembly we bring down up to iliac, so it can be easy to snare in the iliac region rather than in the aortic region. Next slide. Yeah, we can see the whole assembly bringing down up to iliac and stent is in iliac. Next slide. So but at this point of time patient crashed, his blood pressure dropped from 90 systolic to 40 millimeter of mercury of systolic pressure and patient complaining of excruciating angina. So left femoral access was taken. It was mistakenly written right femoral, but at this time we took left femoral access, 7 French EBU was put and LAD crossed with BMW wire and immediately 4 by 36 millimeter sirolimus eluting stent was deployed because our thought was we have to secure LAD because what I think why patient crashed because of that pulling out of that entire assembly there may be dissection in the left main which caused patient the blood pressure drop and caused angina and patient crash. That's why first we secure the LAD with 4 by 36 millimeter sirolimus eluting stent. And as we can see in the third scenario, LAD was well flowing. Next slide. But after putting LAD stent, we noticed significant pinch in LCX ostia, more than 70%. So at this point of time, we decided to go for Kulo strategy to secure the circumflex ostia. And circumflex was crossed, the stud was dilated and 4 by 24 millimeter sirolimus eluting stent left main to circumflex was deployed. Next slide. Yeah, run first. Yeah, that was stent deployment in first scenario. We can see second one. Please run second one. Yeah, in second one, LAD was recrossed, and in third scenario,
Ankur, little louder, I think.
Yeah, in third scenario, simultaneous kissing balloon was done. Next slide. Yeah, in this first scenario, we can see final pot was done, and there is good result at the end of this clot stenting. Next slide. At the end of this colostenting, angina was significantly decreased and patient's blood pressure was started to stabilize. And after that, from the same left femoral route, uh, for that dislodged stent, we introduced 6 French JR and Terumo wire was passed through the stent, and Emplart's gooseneck snap was used to withdraw the stent out of the body. Next slide. So learning points, what I thought from this case is left main to LED crossover ensure adequate ostial coverage, then pure ostial stenting. Adequate vascular bed preparation is essential component in all PCI. For primary PCI, most of the time, direct stenting would be suffice, but whenever osteal disease encountered, intravascular imaging might give you an idea about lesion morphology, SOS vascular bed preparation. And snare kit should be available as part of your cath lab armamentarium and be prepared to use it in once in a while. Thank you. Any comments, sir?
Yeah, of course, Ankur, it was a great salvage. In fact, I was trying to think that almost 80% stent was outside the coronary. Is it correct?
Yes, sir. More than half of the stent was outside coronary and hanging in the aorta.
Mm-hmm. Because at that stage, whether you are going to snare it from above, just when it was protruding out, you could have caught that back end. I mean, if half is there, that's good enough to catch with a snare and pull it out. You decided to inflate the balloon, which was at the distal end of the stent. And the stent will not slip, and that's how you could bring it. Your technique was faster, but at the same time leaves the possibility of damaging the left main because you have an inflated balloon. I'm sure the part of the distal stent is also inflated, and that could traumatize the left main area when you are pulling it out. However, you were quick enough to switch from the other coin and get a BMW into LED. And I entirely agree with you that whenever in trouble on left main, make left main LED passage safe, your patient is going to be all right. So this is something which is extremely important. You should also check, Dr. Ankur, why the stent slipped back. Was it inadequate preparation? And second stent, you have not done a balloon again. So it's not that you prepared the bed differently. So the first stent slipped, and the second stent with the same bed preparation, as I understand, did not slip. So you have any explanation, or you did a
The
balloon
only
between the two stents?
yeah, the second time I had took a larger length of stent. First stent was 24 millimeter, and second stent was 36 millimeter. But actually, I don't know why the first stent slipped because 24 millimeter is good enough to cover the lesion.
Mm-hmm. Yeah, I guess your explanation is very correct. On the second stent, which was bigger, you were pretty deep into LED, and that's how the stent could grip well to the lesion as well as the vessel wall. But if you had time, I would have thought that you should have prepared the bed again between the two stents. I mean, the first stent was out, your wire is down. Once the wire is down, you're safe. And you did not see obvious dissection or anything on the left main, correct? After the first stent was put. So you could have
Is it because
sort
of
of taken time to do a cutting balloon and prepare the bed properly. Yes, Dr. Hundeke, you were saying something?
yeah, sir? Is it because of the gel guiding? Once we are trying to do left main to stenting, we try to position it ostially from left main to LD. So during that, the gel guide might have came away, and that may have dislodged the stent.
Mhm.
So,
I think
guide
it
was not
is,
very supportive.
but he got the stent in position. I mean, jail guide. If it doesn't give support, even then the stent had gone across the lesion into a lady. So I don't think guide will probably make a difference unless when you inflated, the balloon was in the guide catheter. Okay, if backend is caught at the tip of the JL guide, but this can happen with EBU also, isn't it, Dr. Omekari? So that is a possibility that the back end of the balloon, stent balloon, was caught in the. Let's hear from Dr. Nagendra what he thinks about this.
I think what he has done is perfectly right, but the explanation for going with a bigger stand and which have crossed easily instead of a smaller stand is quite difficult to explain. So either the stent was partly inflated while connecting or something, or while transmitting to the guide. That's why it was not crossing. I cannot.
No, I don't think he has an issue about crossing.
Yeah.
Doctor.
Yeah.
Crossing is easy, sir. Crossing was
Easy. First time as well as second
First time
time.
it was
Yeah. Both times. Crossing
Both
was very
times
easy.
crossing was not an issue. The issue is why the stent came back. Sometimes it could be manufacturing also, like the balloon expands and the stent is sort of getting pushed back. I think the stent balloon contact is not good. This can possibly happen. Dr. Jabir?
But sometimes we may not get an explanation for what has happened. But usually what happens is when the stent, just before the inflation, due to the respiratory movements or the guide catheter movement, even before the inflation, in a fraction of a second, the stent moves and then we inflates. Annoyingly, we inflates. Mostly this might have happened. It is not the stent which was inflated, migrated, rather than just before the inflation, it might have migrated and then be inflated. So this is the most likely thing which has happened. Ankur, you did a wonderful job because you saved the life. You were in a difficult position. You are handling a complication at the same time the patient crashed. This is the most difficult and the most catastrophic thing that can happen, which you handle extremely well and quite rewarding. I don't know how many assistants you have. Ankur, can you hear?
Yeah, sir. Yeah.
Enough and more people around.
Yeah, 2 to 3. We have a team of 2 to 3.
But and it's a pleasure for me to see a person from Rajkot. I did my MD in Jamnagar. At that time, there was no cardiologist or cardiology department in Rajkot and Jamnagar. Now there are I think 3 or 6 people there, isn't it?
The total now 25 cardiologists are in Rajkot.
Oh, okay. Dr. Dharmesh was my senior, and Amit Hapani and Babida, both all of them were my seniors, immediate seniors. Okay, good, well done, excellent. It's only problem.
One question I want to ask: in SCS, when we encountered ostial lesion, is it necessary to pre-dilate with NC balloon and cutting balloon to prepare the bed, or like is it in SCS we generally do direct stenting, but in ostial lesion, what is your protocol, sir?
Here the problem was, I thought the circumflex was a dominant circumflex, isn't it?
Yeah.
It was a dominant circumflex. It's a dominant circumflex. It's a difficult game to play around with the ostium. And many of the people believe that there is nothing called ostial lesion of LAD. It is an extension of the distal left main lesion into the LAD. And the ostium, the radial fibers, it's the fiber arrangements and the smooth muscle arrangement is totally different at the ostium. And ostium is a tough area, the LAD ostium. So preference is always now moved from the precise ostial stenting to LM to LAD stent, and it is always better to prepare the bed. It is an acute coronary syndrome, and the lesion looked very soft, but only an imaging can tell us what exactly is happening there. So I would prefer to wire both circumflex and LAD and prepare the bed and go ahead with the LM to LAD stenting. But of course, the problem is it is a circumflex, which is a dominant circumflex across. So we may have to resort to a 2-stent strategy. Dr. Hiramat, what?
Yeah, I mean, it was quite courageous to resort to culottes under this setting. I mean, this was difficult time. Culotte clearly involves many more steps compared to a tap. So if there was no lesion at the mouth of the circumflex, this could have been easily addressed with tap. I think these are all fallback techniques for the side branch. So you can do culottes, you can do a tap, and tap I think is the simplest. So if there was no lesion, it was just a plaque shift. After putting the left main LAD stent, I think we could have gone with a tap also. The angle was quite nice for a tap.
It's a wide
However,
angle.
considering it's a dominant circumflex, I think the respect shown to circumflex is very, very appreciable. And doing culottes will probably be a safer long-term outcome. So I think I would have gone for, I mean, what is done is very, very good. That it's not tap, but it's culot. But it's very individual. Some people might say that tap would work well. However, if the patient was unstable, despite putting left main LAD stent, I think tap works simpler. Like you take a stent, expand, and you don't have to recross and things like that.
This is a small question. In this patient, the left main was very small. So if he could have done a tap, the stent must be hanging in the left main area. So I think that may be the reason he has chosen for the culotte.
No, but he has put in a 4-0 stent from left main to LAD. I'm sure he has done a part. So, I mean, he has obviously achieved the diameter, which is like 5.5 in the left main area. So left main in the initial picture looks small, but I think it's probably a tubular narrowing of the left main, which was taken care by bringing the stent back to the left main option. I hope, Ankur, I'm answering on your behalf and you're with me.
Yes, right, sir, right.
Okay. Very well done. I think very good salvage. I think whenever you run into trouble on left main, I think especially in this situation where left is a dominant circulation, I think the entire onus is on fixing everything quickly. So here, stent was brought down to the right groin, left groin approach immediately, and wire was placed. Once you place wire in the correct lumen, I think you have time to think and sort of strategize your next few steps. You know? Very well done, Ankur. I think a lot to learn from the way you address this difficult complication.
Thank you,
The
sir.
other thing which I generally like, if you had seen a clear dissection in the left main going into LAD, going towards circumflex, I think SKS also becomes a very important fallback option. You get in your wire in the correct lumen, deploy the two stents simultaneously, and you're done. So SKS, I rarely use, but under very critical condition where patient's life is at risk, I think SKS works because it has very few steps to establish flow in a dissected vessel from left main to LAD, left main to circumflex. Of course, you have to be in the correct lumen. So, Dr. Jabir, what do you think? We go on to the next case?
Yes, I also fully agree with you because when the patient's life is at stake, first thing is we have to keep the patient alive with an SKS, and later on we can do many things. If the patient remains alive, we can send later on to surgery also. So keep the patient alive is the most important thing.
These are words of a very mature intensity. All right, we move on to the second case. I think who is presenting second? Dr. Sudham Jare.
Yeah. I'm sharing.
Dr. Nagendra, you are practicing 20 years. You look so young, you know. So I'm very jealous.
I'm 50 now, sir.
Oh!
Jabir, you also did not believe it, right?
Yes, sir.
Okay.
Sir, green arrow at the bottom.
Dr. Nagendra,
Not able
still
to-
the case is set up. I mean, here the stent was pulled back. The balloon was beyond the stent. So
So
it was
I missed that part, I think. So
stent and the entire assembly was brought out. So it
I
saved
think-
time, so which I think is very crucial. So
yeah, so
these are
puncturing
quick
the
steps.
yeah, punching the opposite groin in a 40 BP is also a very crucial thing. So I think it's
Yes.
commendable job.
Dr. Swami, how to share it? I'm not able to share.
So just go to share screen at the bottom, and then once you click the PPT, you will get a window. There you have to click the, you have to first open the PPT, sir, at your end, and then
I have opened PPT. Yeah.
then go to the share screen at the below, green arrow.
I'm not getting it. Only Zoom and I'm seeing the.
Can I present in between?
Yeah, otherwise you can go ahead. Meanwhile, I will make this.
Dr. Sudham, are you seeing 4 icons of participants, chat, share screen, record, and question answer? There are 5.
I'm seeing only one screen, sir. I'm seeing your screen only, sir.
So I think you have pin it. You just click that screen.
Oh, that's
Right.
it.
Click that screen and unpin video. Then you will be able to see.
So in the
Just
meantime,
move
I
your
can
cursor.
discuss one of the recent experience with me. So I was doing a case, and again it was a LED ostial disease, not ostial, actually proximal LED disease and a ramus proximal disease. So I put one stent in ramus and put one stent in LED. And once I was removing the
stenting?
wire of ramus, half of the LED stent pulled back with the wire and came
Was it
in.
V?
So
Did you do a V stenting or you did a
it is
crush?
not a sending. Ramus stent was much beyond the ostium, and LED stent was at the ostium, and ramus wire was always there in the same position. So there was no explanation I could give that why this LED stent came, and only half of the stent came in the left main and stretched, and the rest half was very well there in the LED in the mid part, very well expanded. First time I have seen like this.
Sir, you can
The
escape
only
also.
explanation I would feel
I
is
have to enter again.
when we deflate the stent, we go on negative.
Yeah.
And if we do not give enough time from going negative and pulling the balloon back, I think the balloon is still against the wall, against the stent, and that is how the stent can come back. Also, there are some manufacturers
seeing.
who have a different kind of connect between the balloon and the stent. So if that is stickier, it is with certain companies. If that is stickier, even then this can happen. But very likely, I think simple inflation, proximal LED lesion, quick up, quick down, and you are trying to pull the balloon out.
We can see your
The
screen.
balloon is not fully deflated. That's why.
That may be one of the reasons. Yeah.
Okay, Dr. Onkar, we are
Yeah,
set,
he's
is it?
Yes, sir.
All right, let's go.
Good evening, everybody. I am presenting a case where I was doing a primary angioplasty for LED, and that thrombus was dislodged in L6, and there was a catastrophe. So this is a 42-year male having chest pain of 12 hours duration. That was late presentation. I'm not having ECG right now. Echo was done. It was showing pressure value function EF was around 50%, and some LED territory was looking somewhat hypokinetic. Coronary angiography was done. It was showing single vessel disease. There's a osteoprox LED total occlusion, and left LED was filling retrogradely. So just see this AP caudal view. In this, left main looks normal, L6 is normal, LED is 100% occluded. AP cranial view showing nothing, and LED was not seeing antegradely. And then it was right coronary. It was showing LED was filling retrogradely, and there was a big diagonal which was also filling from retrogradely. So decided to go ahead with primary angioplasty. LED is a big vessel. So I took 6-bench extra backup guiding catheter 3.5, and filter FC was the guide wire. Guide wire went smoothly because going some branch. I was not sure where it is going. So I again took second puncture and swap from retrogradely. So it was in septal branch. So it was then adjusted. So big diagonal, which was filling retrogradely. Then this filter FC wire was manipulated and was landed in LED. It was confirmed again by retro RC issue. That was in somewhat diagonal branch. Anyway, patient was having pain, so I decided I will first dilate and go ahead with further steps. So this was a 2 by 10 mm balloon with that pre-dilated the lesion. So there was some timid flow was started in LED. The nitroglycerin was given as a vasodilator. And then I decided to go ahead with LED stent. There is a lot of thrombus at osteoproximal LED. So there are nothing in L6 or left main what I got at that point. And took 3 by 32 mm Indian drug-eluting stent. I think position was correct. No further movement. It was deployed at 14 atmosphere. After the deployment, there is a thrombus. Whatever thrombus was in LED, it dislodged to L6. And at this point, patient had angina and hypotension. So it was started noradrenaline around 5 to 7 ml per hour. And again, NTG was given. So shoot epicranial view, diagonal somewhat pinched, but that may be mostly thrombotic, I decided. But main issue was this L6, having pain and hypotension. So I passed one BMW wire in L6. Thrombus suction was done with thrombustor, 2 to 3 passes were done, but it was not useful, no thrombus came. It was 6 French EBU, so this LED wire, with these 2 wires, this thrombustor was not going. So I removed the LED wire and done thrombus suction of this L6, but nothing was fruitful. Thrombus is still there. We will give some thrombolytic agent, whatever available in that cath lab that day. We have streptokinase. So I given the 5 lakh 1/3 dose of routine intracoronary streptokinase was given. Still it has only over 2 to 3 minutes, but not. Then I freeze L6 balloon around 12 atmosphere. There was slight improvement, at least pain was somewhat relieved and BP was okay. Then again I passed wire in this LED and post dilated. I have done pot with 3.5 by, do not pot actually, but proximal part of LED was dilated, post dilated with 3.5 by 12 mm, NC bonnets 16 atmosphere. This is the TIMI3 flow in LED. L6 flow is also TIMI3. There is somewhat haziness, that means thrombus is there. So I decided to continue with start low dose of tyrothiban and continue for next 12 hours. That is half dose, 3.5 ml per hour. I started to in this patient. There was no bleeding, no bleeding at the puncture site or any other issue. Next day I took, this is the final result of the same day. And overnight we continued this tyrothiban, and next day the thrombus was there, it was cleared. That noradrenaline 3 to 4 hours I require on that day. After that, its requirement was stopped. The patient settled, and third day I discharged the patient. The check shoot on. I think lesson here, any doing osteal or osteal LED, I think we should use a big guiding catheter and wire the L6 when we are doing LED plastic. That is what I think at the end of the case. Well, you should ask what panelists think about the case.
Do you also want to suggest that we should do thrombus aspiration first time before deploying a stent?
In this LED, sir, yeah, I think
Yes.
yes, yes. Thrombus load
So-
was so much to, but I think it would have benefited or thrombus load has been reduced.
Okay, can we go off
I have not
screen and get?
thrombosuction in LED.
Dr. Sudham, can you stop sharing?
Yes.
You need to go to the top and then click that button. So you can stop sharing.
Dr. Jabir, what are your comments?
It's a wonderfully done case, and he saved the situation with a thoughtful approach with the pharmacological therapy. This demonstrated two things. The basic, if we do some basic mistakes, then we are in trouble. So whenever you are doing an ostial LED, it's always advisable to have a wire in the circumflex. Never ever forget to have a wire in the circumflex. And retrospectively, you also thought that there should have been a wire in the circumflex. After some years of intervention, we all will do these things. We want to get the case done in a short span of time, and then by the time I'll put the wire only in LED, and if something happens to circumflex, I can wire it. But sometimes it may become impossible, and we may land up in trouble. And second thing is this precise position of LEDs, the stent at the ostium, when there is significant thrombus is difficult, then it's always preferable to stent from the left main to circumflex, because this patient had a circumflex which is not a very big circumflex, and this circumflex ostium appears to be very disease free. In fact, it was basically mostly a thrombotic lesion, and the RCA was also disease free, which was giving good collaterals to the LED. So I would have thought of stenting from left main to LED, and then of course, as Dr. Ramath was pointing out, initially a thrombus aspiration, a left main to LED stenting, and post dilatation with a big balloon. This would have been a better approach. It's of course, wisdom comes retrospectively, but you could, at the end of the day, you could save the patient without any issues. That was a good work.
Dr. Jabir, this patient is in mid-40s. So I think I would deviate, and I would probably put only an ostial LED stent. Actually, I never ever do this. I mean, whenever there is a ostial position, I always bring the stent back. But in this particular case, I would probably be with Dr. Sudham in putting an ostial stent. The other trick is when we are in the early phase of inflation of the stent, like you're trying to go from 2 and 4 and then go to 8 or 10. When we are at 2, I tell my nurse to inject a bit of contrast in LAO view. This has to be done very carefully because that's a worry. But we are probably doing it again and again. This is just to sort of ensure that you are at a good ostial position. Anyway, the stent is up, so you cannot move the stent anymore, but at least it sort of gives you a satisfaction that you are at a good position. So we spoke about aspiration. My strategy for aspiration is I put a balloon. Actually, when you put a wire, you make an injection after giving all this masala, all the dilators, including adenosine and things like that. And you start seeing the vessel properly. You know what length is to be covered. At that stage, you can sort of make a decision whether you want to go for direct stenting. However, even if you take a balloon, take a very small diameter balloon, maybe 2 or 1.5, even if you just pass the balloon, it will sort of light up the vessel which was occluded all this time. So once you realize the problem, I think you can follow your step, whether you should go for aspiration and then a stent, or whether you want to go direct for direct stenting. And under this kind of setting, in a young fellow where you're expecting more thrombus and less atheroma, I would probably oversize the stent a bit and deploy it at a pressure of 6 and 4. But I'm talking of not more than about 10 in this particular case, because you're oversizing, and oversizing will probably not squeeze out the thrombus too much, So just a little bit of oversize and little bit of under pressure deployment. Dr. Nagendra?
I think most of the things have already covered. Just one small question, maybe, that when he was trying to do thrombosuction from the circumflex, because it's a 6 French guide and he could not pass it, and he removed the LED wire. So I think that would be slightly dangerous sometimes, because you are trying to go through the LED stand in the circumflex, because LED stand is slightly in the left main. And if LED stand is distorted, crossing again in the LED stand would be much more difficult. So that is one thing which I think you can comment better, that can cause.
So you're trying to say we should not aspirate from the side branch, or you have to be careful?
I was thinking that even if aspiration catheter is not going, then I would dilate with a smaller balloon in the circumflex instead of removing the LED wire, because that can be dangerous sometimes.
Yeah. I think vessels which you access, play safe under these kind of setting. Keep that and put a fresh wire. I think that's a lesson to learn. Anyway, in a young individual, I would like to get the strut in front of the LCX out of my way for a possible future intervention. So it's not, I mean, even if there was not to be a thrombus at the circumflex ostium, I would probably put a wire in the circumflex. Don't get balloon into circumflex. The balloon should be just looking towards circumflex. So pot, side, and pot. These would be the steps to sort of get a mouth to circumflex open. But here there was obviously something lurking there. I mean, the question here was whether there is a plaque shift thrombus or kind of dissection in that area. So whether to put a stent or no in the first phase was very important. And whatever was done is sort of a learning for many of us. Many in a bigger cath lab would probably image the circumflex to decide what is lying there. But this was outstanding to give lytic on table followed by tyrofibon, and next day you see a thrombus gone completely. So a nice way to avoid a stent on the side branch. So I would think it was very well done. The other little worry I had was whether the stent in LED has come back a bit too much. And even under those circumstances, you can get something which is at the mouth of circumflex if the LED stent has come back. Many times it does not manifest immediately, but it would manifest some months later that there is a ISR at the mouth of circumflex. The tyrofibon, Dr. Ankur, was it given with heparin overnight, or it was only tyrofibon?
It was only tyrofibon, sir. Heparin that day I have not given. I have given lytics. I was worried about hematoma and bleeding. So that day heparin I have skipped.
Because I think when you are using tyrofibon specifically for such a large thrombus, I would combine it with a smaller dose of heparin. It, of course, is a worry for the groin, sometimes even retroperitoneal hematoma. But tyrofibon heparin has a stronger potential. Keep the dose down. Keep the dose to very small, not more than about 300 or 500, definitely not more than 500 every hour in unfractionated heparin, and keep the thing going. And why I'm talking of unfractionated heparin is you can control the usage. If there's a problem, you can stop and the action will go away. So any other comments from all the participants?
I have a doubt. Had we done this, a young patient, 40 years, all the other vessels looks reasonable, in a good shape without much plaque or lesion. Had we done a thrombus aspiration first, multiple runs of thrombus aspiration, whether we could have avoided a stent altogether?
What I think, because initially this 2 mm ox balloon was not going, sir. So there was a defect. That means there was some fibrosis also. So I took box this 2O balloon, and with that I dilated. So my feeling was that there is some fibrosis or some atherosclerotic process going on. So on that line, I took direct stent and went ahead.
Yeah, Dr. Jabir, I think you do OCTs very often, and you can clearly differentiate erosion from plaque rupture. And the thinking is even in an acute setting, if it is just an erosion, you probably leave it behind, maintain them on anticoagulants intravenous for next 48 hours, control them maybe or maybe not necessary. I don't know what is your protocol, Dr.
Because this is a tough situation and a
If you're
tough
doing an
position to
OCT.
put in a stent. If can avoid a stent, that would have been much better. And once the precise ostial stenting, usually the stent strut will be either overshoots or undershoots. If it overshoots and then the crossing in the circumflex, we may not be knowing whether we are crossing through a strut of the LAD stent into the circumflex. Sometimes we can land up in real trouble.
Yeah, but I would not sort of go away from the fact that for primary angioplasty, you need a stent. I mean, if you're doing imaging and then trying to say that, oh, there's just an erosion, and do not then stabilize the plaque with hydrostatin or maybe PCSK9 inhibitor, that's another role. But I think for majority of the labs where I think imaging is difficult, I think we have all gone through these. And if you want to go home and sleep well, I think put a stent.
With a huge thrombus load, the OCT may not give a good image also, unless and until
you have to clean up. Yeah, I think you have to clean up. So interesting discussion. I thought anybody, Dr. Sudham, you want to add anything? Or Dr. Hundekari? Next case in that case?
Yes.
Yeah, so we go to Dr. Hundekari and we'll see what he has for us this evening.
Just Dr. Sachin is loading his case. A small request from organizer to all the participants. There is one poll. Please complete that poll. That would be very useful for us. Thank you very much.
Good evening, sir. Today I am just discussing one case which I started once I started my practice as an individual consultant. So this was my initial days of interventional cardiologist as I was doing this case. So renal stenting, as we know that renal stenting is very thought to be easy for all the cardiologists. So with this, this was a 65 years female with uncontrolled hypertension requiring more than 3 antihypertensive drugs. She doesn't have any other comorbidities. USG revealed normal size kidneys with maintained ecostructure, and renal Doppler was showing evidence of right renal artery stenosis. So renal angiography was done, and this was showing this right side right renal artery lesion, which was tight enough, and there was some calcification. So I thought that I can finish up this case very easily. I was knowing that there is some angulation, some calcification. So usually we don't do dilation for the patients with renal artery stenosis because we most of the times do direct stenting. But in this case, I thought there is calcification plus osseosity. So better to predilate the stent and then go with stenting. So initially, I took the this is balloon predilatation with 2.5 mm balloon. So after balloon predilatation, I saw that the guide was deeply engaged inside the artery, and so that the stent could negotiate very easily. And once I know that there is adequate dilatation, then I think that we can go ahead and do the stenting. So as I was trying to push the stent was not going, and it was stuck up in the lesion. So I thought that stent is not going. We have to dilate again with the bigger balloon. So I was trying to pull back the stent into the guiding, and at the same time when I was doing that, I found that the stent, only the balloon and wire came out, and that stent was not visible. Once we do the scanning with fluoroscopy, we found that stent has dislodged, and it has in the right common femoral artery across the sheath. It has just nearby the sheath. So it came below the sheath. So we are thinking what to do now, because I was alone. It was a peripheral center. Not much help was available. So initially we thought, can we be left alone, or can it be removed? So initially we called surgeon also, but he told that arteriotomy will be much dangerous. So if possible, you can try to do snaring and thing, but snare was not available there. So we sent some person to get a snare, and by that time we started on hyperinization. We maintained the ACT. So repeated ACT measurements was done, because this was a renal stent, not coronary stent. So it was, I think, if it is left alone, it can cause limb ischemia. That was my main issue. So coronary stents was been left alone by many people, which can go below the femoral artery and we can just maintain an anticoagulation. But this was a renal slightly bulkier stent. So thought that can we remove it? So meanwhile, while waiting for the thing, we punctured the left femoral artery, and we tried to pass the because the snare was not available. I take double length thermo wire, and with the thermo wire we are trying to catch up this, making it a snare. We are trying to capture this one, but as we see that it is not aligning properly, so we cannot get proper alignment to get hold of this snare. So get hold of the stent. Then we were waiting. Then once the snare arrived, we kept the ACT in the therapeutic range. Meanwhile, monitoring the pulsations and all. Patient was asymptomatic. So almost for half an hour, we were 1 hour almost waiting for the snare and maintaining ACT. Then what we did is we were passing the guide from contralateral artery. So we found that guide was thinking at the bend. So we did at that time we didn't have the braided sheets to cover that. So what I did is I take one ASD 9 French, and through that I passed 7 French guiding, and through that I passed the snare, so that the thing was giving a resistance to passing the snare into the guiding retro on the opposite side. So with that ASD sheath, and there was kink, but through that I passed 7 French guiding, and through that that gooseneck snare was passed. It was aligned. I can get a nice capture of the stent, and then I withdraw the total assembly. So now I have withdrawn all the things. Then I take the guiding chute from the left femoral artery. The femoral artery was clean. There was no trauma to the femoral artery. Then I then go ahead again and then aggressively dilated the lesion and then stented. And this panel successfully dilated, and the result was nice. So for discussion, this was a case of tortuosity with calcification of the renal artery. So in this case, we have to dilate aggressively and see to it that whenever you are passing the stent, if it is not going, you should never force. And even if you are coming out, you should align the guide properly and then come out. But sometimes because of calcification and eccentric calcification, stent can be get hold into the lesion, or sometimes in the guiding catheter itself, it can once you are pulling back, it can be dislodged because of it is not aligned properly to the guide, and guiding edge can slip off the stent from this margin. So we know that there are renal stents are bulkier, so it can cause ischemia. So whenever possible, try to take out the snare with the help of snares or other methods. There are various methods that are described, like you can just wire it and take out with balloon support with passing 2 and 2.5 mm balloon, and then crossing it and inflate it distal to the stent and just pull back. Or if the snares are available, that is the best things to do. And once you do that, snaring is very important. You should know that how to use the snare. While doing snaring, you should be very sure that your guide is very near to the stent, and then just open the snare and then pull back whole assembly back, not only this snare, because it can sometimes dislodge the stent again. And once we do that, we are very safe, and we are very happy that I can snare the stent. So there are various patient-related factors that can have risk for stent loss, like calcification and tortuosity, as we are seeing in this case. Poor guide or wire supports make necessary the withdrawal of the stent, and crimping of the stent can crimped stents have more chance of stent loss. And operator-related factor like inadequate predilatation can cause stent loss. and forceful withdrawal of the guiding can cause a when resistance is encountered. So this is more true in calcified and tortuous artery. Thank you.
Thank you, Dr. Sachin. Dr. Johan, any comments?
So I think very nice save, and he could retrieve it inside the sheet, so surgery was avoided. So only
would you do surgery or would you leave it alone, just like a coronary stent? See, why I'm saying is, what is the difference between a bigger diameter stent and a smaller diameter stent? They are just mounted on a different balloon most of the time.
Yeah.
So, I mean, worst comes to worst, good, you got it out. But if it was not difficult, I wouldn't send him for surgery. I would just.
Yeah. So generally,
thing,
generally you do profunda and you can leave it like this. But
Yes.
in the main artery, you have to take a call that you want to remove it or you can leave it.
Yeah. Actually, sir, it is recommended when it is above the level of common femoral artery, you have to try to remove it because the course is not very sure. Once it is distal to the common femoral in profunda femoris or below that, you can safely leave it alone because there is collateral circulations there.
So only thing is when you are trying to remove it, the wire also came out. So you tried to remove the wire also, or wire inherently came out? Because if wire is always there, then stent generally is hanging on the wire.
No. Actually, once I was planning to withdraw the stent, it slipped away totally. Means that balloon came away and wire also came away because there was not enough length that was in the renal artery. It came away and then without knowledge, it slipped out.
Okay.
Another option is to try the wire again, try to wire the stent again. We had once we had a problem with a multi-purpose catheter while doing an ASD, a PDA device closure. It broke into many pieces and went up to the pulmonary artery, the distal part of pulmonary artery. Finally, we could wire through the catheter, and then we could not snare it, so we could wire through the catheter pieces and took it out with the help of a balloon. Only problem is it may not be coaxial to the flow, so it will be difficult, but that is one thing we can try. Look, you told it was an initial part of your career, but your thought process was very sharp because you could use the ASD sheath, long sheath, and took it out. So that is why I always said intervention is done with the brain, not with the hands.
No, good. Jabir, I was going to comment on that. Most of the time when people say, oh, I was called when the stent was already slipped out, or it happened in the next lab and I joined, whether right or wrong or true or false, I don't want to get into details, but it's quite commendable that you had such quick reflexes. I mean, many of us like Dr. Jabir, Dr. Chavan, and myself, we would probably think on the similar lines even today after say 20, 30, 40 years of experience. So very well done. But you could have left it also. Second thing is you pulled it out first and then fixed the renal.
Yes.
So in this waiting period, I would have done the renal stenting, finished it, so that you don't waste time.
Yes, this is the retrospectively I think now, but at that time I was very much tensed because the initial days of my career I was not knowing. But
he was disoriented at that time, not Quite
as you get older, as you get older, you realize God is very forgiving, and that's why we all survive.
The problem with the renal stent is the patient was asymptomatic, most likely.
Right. Patient was asymptomatic, and I don't want to give that limb ischemia to him.
The other thing, Dr. Sachin, is whenever I'm doing renal, my strong emphasis is on direct stenting. The issue is, if you have seen, especially if you're doing both renal at one time, this is very important because every time you do balloon, there is a distal embolization. If you do both at one time, there is distal embolization, and this leads to acidosis, not in the lab, but a few hours later in the CCU. Yes. By then, you've already done the damage by putting emboli into the distal circulation. So direct stenting always works in renal artery. Keep a good portion of the stent in the aorta so that the stent does not slip forward. But this is something which I have learned over so many years.
Yeah.
Dr. Jabir, is your number of renal stenting gone down lately compared to
It's
what it
come
was
down
10
like
years ago?
anything. We hardly do renal stenting nowadays. Especially previously, we used to do all femoral, and femorals routinely we do the renal artery angiography. Now we don't do femoral, so we are not detecting also.
Yes.
I mean, little extra effort, to check renal arteries.
Yeah.
But we actually did the first study on behalf of Cordis many years back to find out the incidence of renal artery stenosis, because the quoted Indian references were all quoting at around 1% or even less than that, while the world incidence was around 9 or 8%. I'm not talking of critical renal artery stenosis. I'm talking of even 50% narrowing, which may not be clinically important. But yes, they tell you that this is an atherosclerosis patient. This is somebody who would need a secondary prophylaxis and things like that. So I'm not talking of renal narrowing, which requires stenting, but renal narrowing in general, which needs to be followed and sort of kept a check on before, because since there are two kidneys, a 50% narrowing today you detect, don't do anything. In another 4 or 5 years, it gets totally occluded, and that kidney artery starts shrinking. So even if it is 50%, don't do anything today, but follow it closely. And there are many good ways to follow renal these days. So I'm sure, I don't know, Dr. Jabir, you are doing FFR to renals?
No, we don't do.
No?
Previously, we used
Okay.
to check the pressure gradient, but not FFR to the renals. And many of the people, many operators believe that it is advisable not to really hook the ostium of the renal artery while stenting. Many of them, I have seen many of the people used to keep a wire up, a second wire up in the aorta to prevent the guide from engaging the ostium.
Yeah, the guide should not hit the ostium of the renal artery. That was the entire purpose on putting another wire, which is going up to the ascent towards the descending aorta, so that the guide doesn't. Dr. Nagendra, you are doing FFR, I mean,
Renal angioplasty, like for last 4 or 5 years, I think numbers are just once or twice in a year.
Right.
So they have gone down drastically low, sir. So because now we are always doing DTPA scan and discussing with nephrologists before going for anyone thinking of plasties, so numbers have really gone down. So FFR is definitely just 1 or 2 cases not done.
Yeah, I'm actually born in the earlier era, looks like. We have lots and lots of cases where it has given dramatic results, like total occlusion of the kidney. We have worked, and if the kidney size is preserved, by that I mean ultrasound showing a kidney diameter which is more than 7 centimeter, a total occlusion, you open, the kidney function improves considerably. See, the quality of life for these patients, if they lose the kidney, is very poor. Like they go on dialysis, they live well, but its quality is very poor. So I think if it is an ischemic kidney, which is, see, there are not too many things which are needed. Kidney size is a good guide to decide whether to stent or not to stent. Even in a totally occluded vessel. So if it is there, I mean, we have had lots of cases, I mean, elderly presenting with LVF, multi-vessel disease, you cannot send them for surgery. They are so old, but you correct their renal artery bilateral stenting, their recurrent episodes of LVF also settle. So we have gone through that era where we have seen the good of renal stenting, as well as the decline of overall renal stenting. And we also very rarely do renal stenting these days. But my strong urge is to sort of do direct stenting. This is specifically to get the ostium correct, because the stent is, if you see when you inflate, you would see a waste, so you know that ostium is gripped properly and you have a stent floating in the aorta. This also reduces the distal embolization and consequent acidosis, which might come by way of distal embolization. So renal stenting, generally taken a little lightly, like the boss would do the coronary and tell the junior guy, oh, you finish renal, I'll just see some outpatient. This is the level at which renal is addressed, but not true. I mean, if the next person is equally good or he understands, you can sort of leave it to him. But I don't think renal should be taken lightly because every step is going to be important in these. Any other comments, Dr. Jabir?
No intervention is simple unless you finish it safely.
And I think very important you commented. The last case we have done is a severe AS patient actually came for a tower and he had one LVF episode, but the gradients were not so high and LV was normal, and we checked and his both of the renal arteries are blocked and he was stented with renal artery and LV is 90%, both 90%. So renal artery stenting was done and tower was avoided because then he was totally asymptomatic for tower. Just one episode of pulmonary edema, which was possibly because of renal stenosis.
There's a flash pulmonary edema.
Yeah.
Right.
Very unusual. But the people would differ in their opinion when you have a CTO kind of situation on the renal. Here, the reasoning is very simple. If kidney is shrunk already, maybe you do a DTPS scan to see the functionality. But if kidney size is 7 and above, I think it always works. This is actually a learning from the surgeons. They used to put an aortorenal graft, and they used to always believe that if kidney size is more than 7, it would start functioning and grow to its usual size of 10 centimeters. But very well done, Dr. Sachin. We always say, I'm going to talk to Dr. Sachin in Marathi. Mulache पाय पाळण्यात दिसतात. That means kids' future can be predicted looking at the feet when the feet are very small in a jula, baby jula. So similarly, in the young age of your career, you could think so quickly on so many issues. So congratulations on that. And that is why I think is one of the rapidly growing interventionists in the city of Pune. So I feel proud, Sachin, about the achievement.
Okay.
Dr. Onkar, it looks like, are there any questions in the chat box?
So there is one question in the chat box, sir. There is from Dr. Satbir Singh. He says that should we do any intervention at a center with no snare on the shelf?
Dr. Jabir, you want to go for it? Otherwise, I'll go for it.
It's, you may please go for it. Because I'm sure that you are from an era when there was nothing, yes. only just balloon and the guide catheter and a wire. So you can comment on.
So the answer is very simple, as Jabir says, that don't wait for anything. If you keep waiting, it is unending, you know. So you have to always do advanced march. When I was doing DM, we had no angioplasty. So we used to do an LV angiogram because there was only M mode echo and there was no 2D echo. Now you see any angio done, you don't even see an LV gram, or not a single case they do an LV angiogram. Dr. Sachin, you are probably belonging to that era. Yes. But at our time, we used to always assess the LV. The surgeon needed LV function, very important for him. And of course, we had to resort to that. Once our pressure injector stopped, and my boss, Dr. M.J. Gandhi, said, Hiremat, no waiting. Whatever ECG shows, M mode echo shows, that's good enough. So we used to just tell the surgeon LV is bad or good. And that's how the surgery went ahead. So all that I'm trying to say is you should never stop. I mean, you're an interventionist. You're, of course, doing everything good in the interest of the patient. If we had stopped doing cases just because LV function is not available, I mean, for today's era, it's not acceptable. But in those days, I think the surgery would never have grown. I mean, there were so many poor patients in Sion Hospital who benefited with this aggressive approach. And I learned so many things from the trio, Dr. M.J. Gandhi, Dr. Ashwin Mehta, and Dr. Dev Palajani. These were three together at Sion Hospital, an outstanding combination, a lot to learn from them. So I think, Dr. Onkar, we are coming to an end. Did we answer the question or no? Dr. Jabir, you're going to add to my... So I wouldn't stop for snare, but snare is such a simple thing. I think if you don't have a snare today, you can always get it tomorrow. The other issue is you have these wires which can be looped. Jabir, you want to explain how you loop the wire and make a snare out of it?
Sir, you're on mute.
Dr. Javed is on mute.
I'm on mute.
You can take a wider curve, double up your routine, the double length wire of the thermo and put it through the catheter, and make a loop.
Double length, 260 or 300 centimeters. That is very important. So you put a loop which comes out through the catheter tip, and then by adjusting the two outer ends, you can sort of make a loop wide. Once you catch the fish, you make the loop small, tight. So grab the fish, don't let it go, and get it into the catheter. So many times you grab it in the middle of the stent, loose stent, and the stent sort of, something which is straight, it sort of becomes like this V, and you still draw it into the catheter. Fine. I mean, anyway, once you're in catheter, you're safe. You're not going to lose it. Dr. Nagendra, you ever had to do a surgery to search for the stent, or you just leave it as it is always, or you never lost a stent? That could be another thing.
I've lost many times. So like when we were doing coronary arteries,
So you're
multiple
like
times,
all of
and
us.
previous stents were quite often they came out. So 10 years back, it was quite often that stents were coming out of the balloon, and then you have to tie them, and sometimes they become like a ball, and then you have to remove it with a bigger sheath. Only time I could do a surgery was not because of stent, it's because of the catheter. There was a radial angiography was done, and catheter got looped and knotted in the elbow, and then there is small nick was done, and that was removed. But otherwise, generally stents we could retrieve by way of multiple snares and all those things available. So I think we have
first
tried
5
almost
years
10
of
stents by now.
Now
the
the
first 5 years of my practice, we used to do only balloon angioplasty. So you do a good job, go and talk to the family that everything is fine. And the nurse used to come running, oh, patient has collapsed. And the balloon angioplasty on table used to collapse. Then we graduated to stents. But these were hand cream stents. I'm telling you history of angioplasty as it grew. And Cypher actually brought the first stent. So it had two ends, 8 millimeter on either side. And there was a single thick connector. And they used to be separate, balloon used to be separate. So we used to take the stent out of the packet, mount it on a balloon, hand crimp it like this, and then send it in. So many stent used to slip in the coronary. And so, I mean, we are all like very tuned to snares and things like that. Luckily, it hasn't happened to me for a long, long time now. I hope it doesn't happen to me tomorrow, because when you say something like this, something goes wrong the next day, and then we can meet again next 15 days later, then I will have to say, oh, I had this problem. So I think, Dr. Onkar, we are ready to close.
Yes, sir. Yes, sir.
I think this is a great service done by Dr. Onkar and his team from MCure, bringing all of us together. They understand that stent is not their expertise area, but yet taking so much interest and spending time and effort to get all of us together. I really enjoy this meeting. We have every Saturday afternoon luncheon meeting in Ruby Hall, where we discuss the weak cases, especially the complication, especially some stunning work which had gone in that week. And I never ever miss that meeting, because the inference is also similar. I mean, we have fellows who are 40 years in practice. We have people who are 30 years, 1 year, and so on. So all of them enjoy. We also serve good sandwiches that time. So the house is full at that time. So at this time, we cannot serve dinner or sandwiches, but I'm sure everybody's enjoying the atmosphere at home. Dr. Onkar, you look as if you're in office with so many books at the back.
Yes.
Yes.
Yes,
So thank you for this special effort, and say hello to everybody at the factory. We have a special affiliation or a special affection for MCure because we come from the same city. And Satish Mehta, who is MCure boss, is my classmate, schoolmate from very early days. Very intelligent person. He was in. We had this SSC for the entire state, and he was in the first 5 in the SSC board examination, which used to be considered a great achievement in those days. So I remember those olden days every time I think of MCure.
Thank you, sir. Thank you very much, sir. Thank you very much for your encouraging words, sir, which keeps us motivating, and we feels that we can work better and better with your encouraging words. Thank you very much for bringing out the pearls of discussion, sir, and telling the history of angioplasty as well, sir. Thank you very much being a part, and very nicely you are participating in every fortnightly, sir. Thank you very much. At the same time, I would like to extend my sincere thanks to our moderator, Dr. Jabir, sir, and Dr. Nagendra Chauhan, sir. And most importantly, our speaker today, Dr. Sachin, Dr. Sudham sir, and Dr. Ankur sir. Thank you very much for sharing some interesting case today, and a larger audience who are participating across the various platform. I thank you for them and wish a good evening and good night ahead. Thank you very much.
Thank you,
Dr. Onkar, before we actually close, the dose of intracoronary lytic, I mean, like Dr. Ankur used streptokinase, but we like to use TNK in the intracoronary thrombus. So the indications are not many, but when it is really, really necessary, it really works. I mean, everything else has failed, and we are looking around for help. And there, this lytic therapy has helped. I think there are many of us, the senior ones. I mean, there was not too much of legality, I think, in early days. We have used just because we are desperate. We want the thrombus out. So I think you should give it a thought. The smallest vial currently available of Alexim is 30 milligrams, right?
Yes, sir. Yes.
30 milligrams. So intracoronary dose is very small, something like
10.
5 milligrams or maybe. Yeah. So you give one bolus and maybe you repeat another bolus. So it should be a 5 milligrams. So just give it a thought if you can make some small milligram vials, like 10 milligram or something like that.
Yes.
Because most of us feel sad to waste those 20 milligram which are going to be thrown away. So if you can come out with something, this is especially for the cath lab usage.
Yes.
I hope people don't generalize this and give it as an intravenous dose. But I think we all, as interventionists, do understand the importance of small dose TNK.
Thank you, sir. We will definitely convey your message to our R&D team, sir, and we will. I will be personally updated on this, sir.
Thank you.
Thank you, sir. Thank you very much.
So bye-bye, everybody.
Thank
Good
you.
night. Thanks to my permanent help, Dr. Jabir and Dr. Nagendra Chauhan.
Anytime, sir. Anytime.
And of course, the presenters keep changing. So we have different flavor. Like we had doctor from Rajkot, Pune, and Nagar today. So let's keep mix of different levels, so we all understand how to go about it. Thank you indeed.
Thank you, sir.
Thank you. Thank you very much.
Night. Take care.
Good night, sir.
Good night.
Right.
Kajal, are you there?
Yes, sir. Yes, sir.
Very nice, very nice, very nice. We'll stop here. Otherwise, it
Yes.
will.
Yes, sir. All right. Good night.